Thank you, Valérie. Hello, everyone. I'm happy to be with you this afternoon. I have to say that I'm quite impressed by the organization of this convention. Congratulations to the organizers. So over the next 30 minutes, we're going to be talking about pulmonary hypertension in connection with scleroderma or other connective tissue diseases, but more specifically scleroderma. My purpose is, first of all, to describe pulmonary hypertension. I want to also describe the various forms of pulmonary hypertension and the risk factors for developing pulmonary hypertension, particularly in persons with scleroderma. I'm going to be reviewing the many developments that have happened in treatment and screening for pulmonary arterial hypertension, which is a very specific form of pulmonary hypertension. I will also be discussing future treatments and the importance of research into pulmonary hypertension, and then, of course, we will have time for your questions at the end. First of all, what is pulmonary hypertension? The first thing is to become a bit familiar with how the lung functions. The role of the lung is to oxygenate our blood. To do so, the blood has to come into very close contact with the air we breathe. And basically, there has to be very close connection between our blood vessels and the air we breathe in, and the organ that takes care of that is the lung. To do this work, pulmonary circulation basically looks like a tree. So much as in a tree, you've got a major trunk, you've got large branches, small branches, all the way down to the leaves of the tree. And pulmonary circulation works in exactly the same fashion. You've got a major trunk, the pulmonary trunk. The lung vessels, the pulmonary vessels, take the blood towards the small alveoli, which are basically the trees of the leaves of the tree, rather, and the blood will be in contact with air. So pulmonary circulation works exactly like a tree. And at each heartbeat, well, the heart is divided in two, so you've got the right-hand side. The right heart, or right ventricle, pumps the blood through the vessels in the lung to send it to the small branches and all the way through to the leaves of the tree to be oxygenated. What is pulmonary hypertension? It's an increase in pressure in pulmonary blood circulation. So the pressure of the blood in the pulmonary blood vessels increases, and that's called pulmonary hypertension. Contrary to arterial hypertension, you're familiar with that because you've had your blood pressure taken with a blood pressure cuff. That's very frequent with few symptoms. But pulmonary hypertension is an entirely different thing, as you will be seeing. It's rare, it is full of symptoms, but it doesn't occur very often. So that is pulmonary hypertension, of which there exist four major forms. To see these forms, you have to understand how pulmonary circulation operates. I told you that it's a little bit like a tree, which takes the blood towards the extremities of the branches, towards the leaves, and once the blood is oxygenated, a second tree takes the blood back towards the left side of the heart. And this blood is oxygenated and has to be pumped everywhere, to our brain, to our kidneys, to our muscles, and so on. A frequent form of pulmonary hypertension occurs when there's a problem in the left heart, following, for example, an infarct. The left side of the heart can operate more poorly, and thus pressure increases. And that obviously leads to an increase in the pressure throughout the pulmonary circulation, which leads to pulmonary hypertension. That is not uncommon in the general population. Another form of hypertension is if the lung is sick with emphysema or pulmonary fibrosis, for example. It's as though the leaves of the tree got sick and the tree began to die off and the sap doesn't circulate properly throughout the tree, and that's what happens in the lung. The blood doesn't circulate so readily through the pulmonary system, and therefore you get pulmonary hypertension, which is secondary to a lung disease. In the general population, this is a fairly widespread form of hypertension following emphysema, fibrosis, or things of that sort. Another occasional form happens after pulmonary embolisms, which are clots that generally start in a leg and lodge in the lung. They, generally speaking, dissolve in the following weeks after the embolism, but in some patients they do not dissolve, and they block certain branches of the tree and cause pulmonary hypertension. So pulmonary hypertension subsequent to pulmonary embolism. And this form of hypertension is fairly frequent in the general population. There is another form called PAH, which is due to a narrowing of the small vessels of the branches of the tree. This is very rare in the general population, but more widespread among persons with scleroderma. And I'm going to be focusing more specifically on this form of pulmonary hypertension. In this diagram, you can see that this form of hypertension, pulmonary arterial hypertension, is characterized, therefore, by a narrowing of the small branches of the tree. You can see it on the diagram. This is the tree that I was talking about. If we take one of the smaller branches, normally speaking, it is a tube that sends the blood through. And if you look into the tube, you see that in a normal subject, it's nice and open and it allows for a good circulation. But when people have PAH, pulmonary arterial hypertension, there's a narrowing of this tube, and little by little this continues and hampers the proper circulation of blood in the lungs. So you'll understand that when almost all the small pulmonary vessels have narrowed in that way, the blood does not circulate properly, and that leads to pulmonary arterial hypertension. Pressure increases in the lung vessels, the pulmonary vessels, and it makes it more difficult for the heart to pump the blood with each heartbeat towards the lungs so as to oxygenate the body. So how does this look in a human body? Well, on the top left-hand side, you see a cross-section of a small pulmonary vessel. We see that it's nice and open in a normal subject, a healthy subject, whereas with PAH, you see that it's more and more narrowed and sometimes entirely blocked. So you can understand that the pulmonary hypertension is therefore a problem, and the blood is poorly oxygenated, and it's more difficult for the heart to pump blood. Pulmonary hypertension is an increased pressure of the blood in the pulmonary system, but there are various forms, as I've already explained, due to left heart disease or respiratory disease or embolism. And when none of these diseases is present, we know that it's due to PAH, pulmonary arterial hypertension, a narrowing of the blood vessels. Now, PAH is much more frequently observed among scleroderma patients who can also have other types of pulmonary hypertension on occasion. You no doubt know that from time to time, scleroderma can lead to lung fibrosis, pulmonary fibrosis, and therefore that also could trigger pulmonary hypertension. Scleroderma can sometimes affect the left side of the heart and trigger pulmonary hypertension due to the poor functioning of the left heart. So there are other reasons why you might have pulmonary hypertension when you have scleroderma. What are the risk factors of developing pulmonary arterial hypertension, or PAH? As we've seen, there are several forms of pulmonary hypertension due to heart disease, respiratory disease, chronic embolism, and PAH, which is due to the narrowing of lung vessels. Often it is idiopathic, meaning that there's no clear cause. Often it affects young women and there's no underlying disease or other disease, and so there's no way of accounting for it. There are hereditary forms, in other words, several cases per family, but often when PAH is diagnosed, it's because it happens in a context where the patients have an underlying disease which has predisposed them to the onset of pulmonary arterial hypertension caused by the narrowing of the small vessels in the lung. There are several diseases that predispose to the development of PAH, such as HIV infection, hepatic cirrhosis, and others. But scleroderma and other autoimmune diseases connected to that disease, such as lupus and other connective tissue diseases, these are all diseases that predispose you more significantly to developing pulmonary arterial hypertension. When PAH is diagnosed, in more than half of cases, we see an underlying disease which has predisposed the patient to developing this disease. These are what we call the associated or associative PAH cases. More than 50% of cases are involved, and this is often connected to a connective tissue disease, including scleroderma. So even though PAH is a rare disease, it is unfortunately very often present in people who have scleroderma, and we will see what this means a little bit later on for scleroderma patients. So here I'm showing you the same statistics in a different form. In more than 50% of patients, there's an underlying disease that predisposes to the development of PAH. Most frequently, this is a form of connective tissue disease, and the most frequent of that is scleroderma. So scleroderma is really the disease that most predisposes patients to the development of PAH in its diffuse and limited forms. What does this mean in numbers? As I mentioned, PAH is a rare disease. The narrowing of pulmonary vessels in the general population is very rare. It's in fact an orphan disease. We think that about 600 to 800 persons in Quebec alone are afflicted with a PAH, so it's very, very rare. Conversely, when you have a condition that predisposes you to PAH, you will have it more frequently than would be the case for the general population. More particularly, for persons with scleroderma, we think that it's about 5 to 8% of scleroderma patients who will one day go on to develop PAH. Over the last 30 years, A number of studies have examined the proportion of patients with scleroderma who will go on to develop pulmonary arterial hypertension and what are the risk factors for scleroderma patients that would allow us to predict who one day will have PAH. So we're talking about 5 to 8% of scleroderma patients who will have PAH, and when we look at the risk factors among scleroderma patients, the risk factors for one day developing PAH, we see some small signs, but there's no reliable marker that allows us to predict reliably who will go on to develop PAH and who won't. We know that on average it affects scleroderma patients who are a little bit older versus those who don't have PAH. Generally speaking, we're talking about people who've had scleroderma for several years, many years. But even if scleroderma is a recent diagnosis, there is no certainty that you will or will not develop PAH in the short term. In fact, we have some patients where PAH is diagnosed, and later on we diagnose the underlying scleroderma. In other words, PAH was diagnosed before scleroderma. That can happen too. In the past, it was said that PAH affects CREST syndrome, limited forms of scleroderma, and diffuse is not affected. But we know that is no longer true. All things being equal, PAH is as frequently observed in diffuse as limited forms of scleroderma. One risk factor we've identified is a drop in DLCO, which is one of the measures we take when we measure respiratory function. You've probably already used a machine such as the one on the top right-hand side, which measures lung function. And one of the parameters that are measured during that test is the lung's capacity to transfer oxygen from air to blood, which is called DLCO. We know that when DLCO drops, this is a factor. This tells us that this individual has a slightly greater risk of developing PAH in future years. Scleroderma is an autoimmune disease, as you know, so we're looking for antibodies when we diagnose scleroderma, and there's some antibodies that predispose you a little bit more to PAH than others. But there is, in fact, basically there's just markers that allow us to say that this individual is at slightly greater risk of developing PAH, but we cannot reliably predict who exactly will go on to develop PAH. The last few years, a great deal of interest has been paid to other manifestations of scleroderma that affect blood vessels, such as digital ulcers or telangiectasias and Raynaud's disease. Researchers have tried to see whether there's a connection between the involvement of blood vessels in the hand and the development of PAH, and there seems to be no clear link between the two. It's not because you have more Raynaud's syndrome or other digital problems that you are at a greater risk of developing PAH one day. So the first message I want you to retain is, first of all, that PAH is uncommon in the general population, very rare. It's an orphan disease, but it is not that rare when you're talking about people who have a condition that predisposes them, such as scleroderma. Nevertheless, the majority of scleroderma patients will never go on to develop PAH. So we're talking about PAH because it is a serious illness, but most people will not go on to develop PAH. At least 90% of scleroderma patients will never develop the disease. It is unfortunately impossible to predict reliably who will and who will not develop PAH at some point in their lives. In the current state of the science, it's impossible to predict this. What are the symptoms of PAH? How can we diagnose this? Well, we've talked about the various forms of pulmonary hypertension, and I've said that it's not like blood pressure that you measure with a cuff. In fact, it's entirely different because pulmonary hypertension does have symptoms. The problem with the symptoms is that they are non-specific. The symptoms, for example, are breathlessness, fatigue, exercise intolerance. Generally speaking, in scleroderma, a vast majority of patients will suffer from fatigue, a certain amount of exercise intolerance. These are not specific symptoms that allow you to determine and predict with certainty that they will go on to developing PAH. When the disease evolves more, there can be swelling in the legs, in the abdomen, pain in the chest, dizziness, almost loss of consciousness when a more sustained effort is made, and sometimes indeed loss of consciousness, syncope in a more advanced stage of the disease. The difficulty is that all these symptoms are non-specific, as I already said. It's not because you have a certain exercise intolerance or suffer from fatigue that you necessarily have PAH. Most scleroderma patients have these symptoms. So the message I want to get across is that we're talking about an evolution, a change in these symptoms. If that that happens, you can think that this might be one of the respiratory complications of scleroderma. Somebody, for example, who could go up 3 flights of stairs last year and is now breathless after just 1 flight of stairs, well, this could be due to all kinds of reasons, but you should bear in mind that it could be a pulmonary complication of scleroderma. And the same is true for all kinds of other activities. What's important is not to wait for severe breathlessness before you consult your physician, as we'll see in a moment. So those are patients' symptoms, but even for clinicians, the problem is that the tools we've been taught to detect, to screen for this disease, such as pulmonary X-ray, electrocardiograms, and other respiratory tests, often allow us to diagnose the disease only once the disease is fairly advanced, so that physicians, particularly family physicians who are not so familiar with this disease, will be falsely reassured by the tests that they generally ask for, that they ask their patients to take, which is why even now in 2016, the average diagnosis between the onset of symptoms and the actual diagnosis, the average time frame that elapses is more than a year. Over the last 10 to 15 years, there's been a great deal of awareness of rheumatologists who systematically screen for PAH nowadays. So that has improved the situation, but nevertheless, it's not perfect. How is diagnosis done? Well, the first thing we have to do is think about it. If we have symptoms that might indicate PAH, particularly if there is an underlying disease that predisposes to this form of pulmonary hypertension. So we should think about it with respect to the patients themselves and the physicians. When we think about a possible PAH, the tool to detect a pulmonary hypertension is the cardiac ultrasound. This is an exam exactly as is done for pregnant women to see the fetus, but in this case it is used to examine the heart. So there's a little gel that is applied to the chest, and there's a little apparatus placed on the skin, and that illustrates the functioning of the heart. You can observe the heart. And then you can estimate. It's not a precise measure, but it allows you to estimate the value, the number for pressure in the pulmonary system. Is it high, is it elevated, or not? So this is a good tool. It gives us a decent idea of what's going on, but it's not enough to make a diagnosis for 2 reasons. First of all, the ultrasound is not 100% accurate. So sometimes it gives us measurement errors where pressure looks very high, but then it's not all that high, or the reverse. Most of the time it is reliable, but it's not sufficiently accurate to allow for diagnosis. So when we truly suspect that there's pulmonary hypertension, we have to do a more invasive and a more complicated examination, a right cardiac catheterization, where a little catheter is inserted into a vein either in the neck to measure exactly what's happening in the pulmonary circulation. Well, it looks a bit scary, but in actual fact, it's not a very complicated exam. What's unpleasant is that when the catheter is inserted, it's a little bit unpleasant. It stings a little bit, but then that's only 15 seconds, and then the exam itself takes some 15 to 20 minutes. And this gives us an accurate idea of whether there is pulmonary hypertension. Now, even in the case of pulmonary hypertension, as I explained earlier, there are various forms of pulmonary hypertension. So more exams are required to determine why pulmonary hypertension is there. Why is the blood pressure higher? Is there a respiratory disease? Is there a left heart disease? Has there been pulmonary embolism? So that we can come to a very specific and accurate diagnosis, because as I've already explained, PAH is one subtype of pulmonary hypertension among several. And treatment will vary enormously depending on the type of pulmonary hypertension we are dealing with. Fourth message, the clinical manifestations of PAH are non-specific, which means that diagnosis can take a long time, and breathlessness should not remain unexplained, especially if there's a risk factor present, such as scleroderma. So if you really feel more breathless than 6 or 12 months ago, you have to get this checked out. It may be due to nothing at all. It may simply be scleroderma affecting your muscles, but you must bear in mind that it could be PAH or another respiratory complication. And the cardiac ultrasound is an efficient and effective tool to screen for PAH, so this is a tool that is often used, but it's not perfect. It's not 100% accurate, so we sometimes have to do some more invasive and unpleasant examinations to determine whether there is PAH present. Coming now to treatment, I'm going to talk specifically about PAH, because when there is pulmonary hypertension connected with a respiratory disease or a left heart disease, then we treat only the left heart disease or the respiratory disease, as we would do for any other patient with left heart disease or respiratory disease, whereas PAH requires specific treatment. There are treatments that target the abnormalities in lung circulation for people with PAH. In the 80s and 90s, people thought that pulmonary hypertension was due to vessel spasm. In other words, rather than having a nicely open tube, the blood vessel was undergoing a spasm, much as in the case of Raynaud's phenomenon. So the same treatments were used as in the case of Raynaud's, such as calcium channel blockers and vasodilators, because that's what people knew at the time. Unfortunately, these treatments were not effective in a vast majority of PAH patients because things in the lung don't operate as they do in the case of Raynaud's. It's basically a remodeling of the vessels that's underway. In other words, the vessels are becoming more and more blocked, but not with cholesterol. That's not what's blocking them off. It's cells coating the insides of the vessels that multiply and stop dying off, and that little by little obstruct the blood vessels in the lungs. So the vasodilators did not work. Until very recently, there was not much treatment available until it was discovered that, now that we're more familiar with the disease, that there are risk factors such as scleroderma and others. And we also know that there's probably a genetic component to account for why 95% of scleroderma patients will not develop PAH, whereas 5% will go on to develop PAH, all of which leads to what we call endothelial dysfunction. What does this mean? Well, inside the vessels, as you see on the top of the screen, the cells coating the insides of the vessels produce various substances which become abnormal when there is PAH. And they tell the blood vessels to basically become more and more obstructed and blocked. It's a little bit unusual, but that's how it works. For the last 20 years, people have developed treatments to block these signals in the lung blood vessels. So until very recently, there were few treatments available. All we had was oxygen for people whose oxygenation rate was low, diuretics sometimes, lung transplantation in some cases, but there was nothing else we could offer. For the past 15 years now, we've seen about 10 medications come onto the market to treat this condition. So that is enormous progress. In the last 18 months, 4 new treatments have come onto the market to treat this so-called orphan disease. So this is a very unusual development and really great progress. And these are treatments that focus and target this endothelial dysfunction. To summarize these treatments, what we know is that overall they improve, well, they don't cure the disease, but they improve parameters when the cardiac catheterization is measured. So hypertension improves, exercise tolerance is improved, quality of life is improved, and survival rates go up. And most of the patients will be treated with oral medication that have few or no side effects. For the vast majority of patients, that is the case. In very rare cases, you may have seen or heard of people who have more complex treatments, drugs such as the one on the right-hand side, intravenous 24-hour-a-day treatment. Well, this is a very complex drug to administer, very complex for the patient, but it really affects only a minority of patients. The choice of treatment depends on all kinds of things. First of all, the type of pulmonary hypertension we're dealing with. As I've said, these treatments are effective for persons with PAH, not the other forms of pulmonary hypertension. And the choice of treatment will also depend on whether there is spasm in the lung vessels, and that can be determined during the catheterization process. It will depend on the severity of the disease, patient preference, the patient's ability to manage the medication, particularly the intravenous medication I mentioned earlier, which is very complex. It requires a certain amount of dexterity. So not all patients can use that kind of treatment. It also depends on side effects and response to treatment. Basically, every patient is unique. So if there are people in the room who have PAH, if you know other people who have PAH, well, you probably not all getting exactly the same treatment because every patient with PAH is unique. What influences the choice of treatment is, to a large degree, the severity of the disease, which is assessed according to various parameters, but essentially symptoms, the patient's capacity and abilities, and how the right side of the heart, which pumps blood through the body, how well it operates. And that is a marker of disease severity. And therefore, treatment is tailored as a consequence of that marker. One question that often comes up is, if I have PH in Canada, am I going to be as well treated and taken care of as elsewhere? Will I have access to the medications that are available elsewhere? And the answer is yes. You see all the treatments available worldwide and in Canada. In Canada, there are 2 drugs that are not available, that are available in the United States. They are both given as inhalants, but basically these are two very expensive and not very effective treatments. So even if they were available in Canada, very few patients would be given these treatments. So the answer to your question is yes, in 2016 we can consider that a PAH patient is as well treated in Canada as elsewhere in the world, and particularly in the United States and Europe. Another question that can arise is if the disease is due to scleroderma, so we're treating the endothelial dysfunction in the vessels, but why don't we treat scleroderma, which is the underlying disease that has caused the PAH? Well, the problem is that it's more complex than it appears, but this has already been tested, and there are some connective tissue diseases that are more inflammatory. In other words, autoimmune diseases that cause significant irritation to the lung vessels, as is the case for lupus or mixed connective tissue diseases. And sometimes those are treated with treatment that reduces the irritation and inflammation of the lung, which in some cases can improve pulmonary hypertension. But when we're dealing with standard scleroderma, as it were, these treatments don't work. And they unfortunately entail side effects, so they are not used. But you'll see in a moment that in future treatments that I'm going to be talking about, there are some scleroderma-specific treatments that are under review now to treat PAH. Now, prognosis and outlook. PAH is a serious disease, obviously. For the last few decades, we've known that among the scleroderma patients who die from scleroderma, PAH is unfortunately one of the most frequent causes. So this is a serious complication of scleroderma. Although things are improving, here you see the survival curve in the 1990s for persons with PAH. The way we calculate the survival curve is that we see the number of patients alive after X number of years. So if we diagnose 100 persons today, we see that progressively as years go by, people will die of the disease. And in the 1990s, from the moment of diagnosis, only about 50% of the patients were still alive 2 years after the disease. So as you see, it's a very, very serious complication of scleroderma in the 80s and 90s. Survival rates have much improved. From the moment of diagnosis, we can now say that at least a patient has at least 80% of chances of being still alive 3 or 4 years down the line. So that's much better. What this means is that patients can now have a much better life expectancy in patients who've had the disease for more than 15 years, who have a relatively normal quality of life. So that's one side of the medal. What this means is that current treatments improve survival of patients. The other side of the medal is that the improvement is not enough. In other words, having 80% of chance or survival chance after 3 years is good. It's better than nothing, but it's not good enough. We have to improve things. How can we improve things? There are various different ways, and one of the ones we're focusing on now is combination therapy. In other words, to opt for more than one treatment at a time to target PAH. Another way is to screen, to test for the disease and detect it earlier. Over the last 20 years, it has become suggested that we systematically screen scleroderma patients for PAH. So there are all kinds of ways of doing this, screening for the disease. What is currently recommended is that we systematically, annually carry out respiratory function tests and a cardiac ultrasound to see whether there are any signs of pulmonary hypertension, and if yes, or if there's the slightest doubt, to carry out a right cardiac ultrasound, right cardiac catheterization. Now, there are two things I should point out. First of all, very few patients will develop PAH from one year to the next. So when you look at the studies, it's less than 1%. If I have scleroderma today, for example, I have less than 1% risk of developing PAH in the coming year. So the risk is very, very low. So the question we have to ask ourselves is whether we're doing too much if we make everybody undergo an ultrasound every year. So that's one side of the argument. Conversely, we also know that ultrasound can sometimes give a falsely normal result. So we have people with PAH, which is not really visible on the ultrasound. There's no sign of PAH on the ultrasound. What this means basically is that you have to use the ultrasound on the basis of the patient's symptoms. So you have to suspect pulmonary hypertension, carry out a cardiac ultrasound. In someone with few symptoms, with a normal ultrasound, you can be reassured. In someone with symptoms that would seem to indicate PAH with an abnormal ultrasound, then obviously you have to investigate further using right cardiac catheterization, among other things. But you should bear in mind that in the case of a patient who is breathless, where there's no clear cause, we don't see any other reason for the person to be more breathless than in the past. Even if the ultrasound is reassuring, you should nevertheless think that it can be a false normal, and you have to investigate further. These are the outcomes of a major study carried out over the last few years and that have shown that it is necessary to take it further. So currently there is no screening algorithm that is 100% infallible. Even with a screening system that is well developed, it is possible to develop PAH without it necessarily being diagnosed, and a cardiac ultrasound is not enough as a screening tool. If, as a clinician, we're very much afraid that somebody has PAH, even if the cardiac ultrasound is reassuring, we have to investigate further. And you have to keep an eye on other symptoms. If, for example, there's more breathlessness than in the past, you have to ask yourself some questions, and your doctor should also be asking questions. And finally, the other way of improving survival is to develop new treatments. I talked about endothelial dysfunction earlier and the treatments that have been developed, but we know that the situation is more complex than we thought. So in pulmonary circulation, when there is PAH, you have far fewer vessels than in a normal subject, and the vessels we do have are narrowed. For the past 10 years, we've become much more familiar with the whys and wherefores of this narrowing, and why we have a vessel that is not like on the left, nice and open, but we have a narrowed vessel because the cells inside have proliferated. So all the little lines are the mechanisms that explain why the cells proliferate and block the vessels. Currently, with current treatments, we're simply targeting endothelial dysfunction, but there are many other mechanisms at play that have not yet been targeted by current treatments. So another possibility is to develop treatments that will focus on other dysfunctions. So there are all kinds of treatments that are currently being assessed. They are in clinical trials involving patients, and they target other aspects of the mechanisms that lead to the development of PAH. The only way of doing this is through research. The only way for things to improve, and the reason they've improved now versus 20 years ago, is thanks to research. And the only way to make things better in 10 years from now is through research. I'm convinced that in 10 years' time, PAH will not be treated the way we treat it currently. Just to give you an idea of the research that's ongoing in pulmonary hypertension, I just want to show you a tool that we use as researchers. It's PubMed. It's on the internet. It's available to everyone. And you can enter a subject such as pulmonary hypertension, and the tool will list everything that has been published over the past 70 years. So if we put in pulmonary hypertension, we see all kinds of titles being published. These are the titles of articles. So we see a page like this that pops up, which contains 20 articles, 20 studies on pulmonary hypertension, and each article describes the outcomes of experiments on cells, on animal models, on humans, aimed at improving pulmonary hypertension. Specifically, among my students, each title corresponds to the equivalent of 1 year's full-time work, just to give you an idea of the scope of this work. But you will not see a page like this. If you put in pulmonary hypertension, you will get 2,600 pages popping up. And if you look at the number of studies published in the past, for 10 years there are only 28. But look at how this has increased. 52,000 currently in 2016. So this shows you how much interest is being devoted to this topic. There's a great deal happening in research, and things keep progressing. In 5 or 10 years' time, things will have enormously changed. So just to make the point that in Canada there are several pulmonary hypertension research centers of excellence, and we have a research group that's doing translational research, as it's called. You've probably heard about it from another speaker this morning. Basically, the purpose of translational research is to improve things directly for the patients. In other words, to start from a problem that affects patients, understand why it affects patients, and then lead to better treatment and improvement for the patients. And specifically in our laboratory, 6 or 7 years ago, we identified one of the reasons for which the blood vessels were obstructed through PAH, and we are soon going to be launching a clinical trial that specifically focuses on another abnormality of the lung vessels, which we think is a very promising line of research. So in conclusion, PAH is a frequent quote-unquote complication of connective tissue diseases, particularly scleroderma. It's frequent because it's much more widespread than in the general population, although a majority of scleroderma patients will never develop PAH. Screening allows for earlier diagnosis, but it's not enough. You have to pay attention to your symptoms. Current treatments improve life for most patients with PAH in terms of quality of life and survival, but there are still problems. So the challenges are to develop early biomarkers. We're screening people who already have the disease now. In future, we would like to be able to screen people and detect the disease before they develop it. And new therapies, obviously, are going to be promising as well. Now, here are some resources if you would like to research this a little bit more, become a little bit more familiar with pulmonary hypertension. All of this is available on the internet. And I'd also like to introduce our research team. I present, but others are working in our laboratory. So here's the research team on a Monday morning. They're smiling, they're happy, they love to come and work to progress in the field of pulmonary hypertension. And even after a 10K race, because we recently did a 10K race on behalf of PAH, they're still smiling. Thank you very much for your attention. I'll be glad to take your questions.